I'm Carly Kramer. I'm the founder of Beekeepers Naturals, and this is the science of fertility. Let's get into it. You had me do so much blood work that I had to do it over the course of 2 days because I didn't think I could go to work.
I just want to clarify that that was your choice, and it was very much a safe amount to have Sean in one day. But I know how much you love, I think we've alluded to in other episodes, how much you hate blood work and just
Everyone think I
blood
feel like
draws.
it seems like I'm being a little baby or I'm being dramatic. I actually faint though. Like
No,
everyone
it's-
should know that I actually faint. This is real.
I've never felt that you were dramatic. I promise you that, except for when you chose to split it over 2 days. But that's okay. It felt right for you, and that's okay. But yes, all that to say, we did probably the most, I mean, maybe there was more, but we did the most possible for you.
Because we did blood work and testing before my last pregnancy.
Right.
And that was like half the vials, I feel.
Yeah. Yes.
So my first pregnancy, I guess that was the essentials. And then we went extra for new testing.
Yeah.
What are the essentials? Like, what are the things that you're testing me for first pregnancy?
Yes. The essentials really correlate to the endocrine system. So our endocrine system is just every organ in our body that makes or produces a hormone. Our thyroid's one of the stars of the show. She's our cute little butterfly-shaped organ in the front of our neck. We love her. She's wonderful.
So thyroid's actually huge in getting pregnant, which we learned because my thyroid was completely off. And that's why I had an issue.
Right. And what's interesting is generally the only thyroid hormone tested is what's called TSH, or thyroid stimulating hormone. That's a standard of care. We just look at her until she's out of range. We don't care further. And that bothers me. And this is so important for anyone that's listening. If someone has told you your thyroid looks fine, but they only tested one thing, find someone else or do some more digging.
So what do you want to be testing?
TSH, free T4. So T4 is one of the main thyroid hormones. We make more T4 than we do T3, but T3 is our other thyroid hormone. We like the free version of both. The free version just meaning it's unbound to a protein and biologically active in our system. Can you test
for the free and not free?
You can, yes. Yeah, free and total. Not necessarily, no. The TSH, which we want a high sensitivity measurement of the TSH, it just means they're slightly more accurate in the lab. So TSH,
what does high sensitivity mean? Does that mean we're doing it fasted or there's...
It doesn't, no, it's just the way the lab measures it. So it's lab specific. And so it just allows them to be a little bit more accurate, to be totally honest, when they're measuring the TSH. But to your point, I do want to see thyroid fasted and ideally before 9 a.m. because we do have a circadian rhythm to our thyroid hormones. And so looking at it in the morning and in a fasted state, because it can be impacted by food, is important. So I'm glad you mentioned that because that is another key thing. So the TSH, the free T4, free T3, and then the other two that are always missed that I think are so important to ask for is ask to be tested for Hashimoto's thyroiditis. You can say those words. You can just say Hashimoto's, ask for that. And the reason is, and I don't think people understand this, and that's why I'm excited we're talking about it, because Hashimoto's thyroiditis is an autoimmune disease, which essentially means our immune system woke up one morning with a vengeance on our thyroid when we didn't ask her to, and she just decided to start attacking our thyroid as if it's a foreign invader. Obviously, we've had her since we were growing in utero. It's a mistake that happens in our immune system, and that's what constitutes an autoimmune disease. And why Hashimoto's is so important is, yes, it's the most common cause of an underfunctioning gland, meaning hypothyroidism, but it actually can exist separately, meaning if we just looked at your TSH, it could be totally fine. Let's say it could even be beautiful, but you could actually still have Hashimoto's thyroiditis. And there's 2 blood tests that we can ask for that can tell us if we have Hashimoto's. And why that's pertinent is it can increase our risk of miscarriage rates. And so having that information could help you share with your provider, like, hey, I have this. I understand that I may be at a slight increased risk of a miscarriage. What are some ways that you can support me in those first few weeks of pregnancy to help mitigate that risk?
So I'm going into a clinic or just working with an EOB. She's probably just going to test my TSH.
Probably, yes.
And
that's your annual screening. That's where it's ending.
And I am going to demand.
You're going to put your little foot down because you have small feet, which I love for you.
They are little.
And you're going to demand a TSH that's measured high sensitivity. They're going to be like,
do I have to say high sensitivity?
Yes, you
really?
do.
Okay.
Yes, because they won't.
Okay.
You have to ask that, and they'll go, how do you know that? And you'll go,
I'm a doctor.
I listen to this podcast, is what you would say.
They love that.
And then you're going to ask for free T4. That's all you have to say. Free T3. And Hashimoto's thyroiditis antibodies. Those are the words. You can memorize those, practice in the mirror, whatever feels right. Write them down. We'll have some details in the show notes.
Practice in the mirror,
practice in the mirror. That would be me too if I didn't know the jargon. Because it's just jargon, right? And you don't know what you don't know. And I think that's why I love that we're doing this episode especially, because we're just given the order for the blood test and you go and you get it done. They take your blood.
I actually
and sometimes you don't get a call.
I really had, and will continue to this pregnancy, I had to advocate for myself really aggressively, and you were pushing me to, because we know that my thyroid's low. I have hypothyroidism.
Right.
And they didn't want to keep testing. And I had to push for tests. And, you know, had I been with you, I was traveling. So I was working with a few different OBs in different places for work. Where I was, and they didn't want to test again. They're like, let's wait a little bit, and I texted you, and you're like, no, you test it now. And we tested, and lo and behold, we had to change my medication.
Right, and that's one thing in particular about your thyroid is, I mean, there's a lot of demands on the body when we're pregnant, but your thyroid undergoes a lot, and it's not uncommon to have pretty significant or consistent or just. It's not uncommon to have to change your dose throughout pregnancy. And I think it's important to know that you can advocate for it being tested.
Because the thyroid affects the baby's development and also really changes throughout the course of your pregnancy.
Yeah.
And so testing it, how often, let's say someone has hypo or hyperthyroidism, how often do you want them testing their thyroid throughout pregnancy?
I would love to see it every 4 to 6 weeks. I know there might be some OBs that could potentially roll their eyes at that. And I totally appreciate that the standard of care is generally once a trimester. So once every roughly 12 weeks, right? It can change pretty quickly. And it takes about 4 to 6 weeks to see how a dose adjustment affected the thyroid. So testing too early is negligent. Like testing every week, we're not going to get value from. It's going to have fluctuations. And I won't be able to see how that dose change in medication really impacted you. So I would love, especially if it's first pregnancy and or if it's like a newly diagnosed thyroid condition, I would love to see it every 4 to 6 weeks. And then if we see that it's stable, let's say 2-3 times in a row, then we can kind of say, okay, is this more of a stress for your life than it is helpful? I have some patients that are like, okay, I feel good. I feel comfortable with where it's at. And I'm like, okay, great. I really want my patients to feel like they're in the driver's seat and I'm here to be like their educational resource, which I know is kind of like how we've worked too, of like, hey, these are the things that we can do. But if it's so stressful to continue to do it at that cadence, then know that at any time we totally can pull back. But that would be best case scenario. And what's actually interesting and kind of a fun fact is the thyroid is actually the first endocrine organ to form in utero. So as babies, it starts roughly around week 4, but it's actually week 5 that baby actually has a thyroid that's developing. And it comes from the base of the tongue and travels down. Other fun facts. So super interesting. So your thyroid hormone production, super helpful for theirs.
And not to freak people out. And obviously babies can be totally fine, but there are studies that have shown that
hypothyroidism.
So hypothyroidism can lead to neurological impairment if untreated. So basically every time we tested my thyroid, we changed my medication, and every single time, even the OBs that didn't want to test were like, okay, that was the right thing to do. And so what is that link? Why does my thyroid dictate my child's neurological development?
The thyroid's kind of like the cash currency for metabolism within your body as mom, but also for baby. When we say metabolism, that also includes like the growing and the breakdown of products. And so baby's actively growing. If baby does not have enough currency coming in to continue to grow, it will sacrifice its growth in areas. And that can be in the neurological department where brain is sacrificing how it's growing. And that is what can then happen. And we notice it obviously later on in developmental years.
So we know what to ask for with thyroid. What are the other foundational things, the things that you tested me for first time around?
Yes. Other foundational things are I want to stick to the hormone piece to kind of like bring that together. So then I think about our sex hormones. Sex hormones are just hormones that are created by cholesterol, essentially. So that's kind of the backbone of the hormones. That includes testosterone, that includes progesterone, and that includes estrogen. Now, estrogen is technically an umbrella term because we have different types of estrogen in our bodies. As females, as menstruating females right now, we have two main ones, estradiol and estrone, that we can measure. Two additional ones become more apparent during pregnancy, the fourth one rarely ever being tested and actually not as well known. But all that to say, those estrogens are important. So then we talk about the timing of testing those. So ideally, in a perfect world, I'm doing 2 blood draws with a first-time fertility patient. The first one being between day 3 to 5, second one being 7 days after ovulation. And that's where part of, knowing where ovulation is happening is helpful. So that day 3, we're including hormone-wise FSH, LH, and estradiol. So FSH and LH are the 2 hormones from the brain that travel down to the ovaries. They're like the movers and shakers. They're helping the ovaries pick one dominant, what we call follicle, just a fluid-filled sac that houses one lucky egg. It's going to pick one that will hopefully ovulate. That's FSH's role, follicle stimulating hormone. We're not that smart in medicine. We name it pretty directly sometimes. So there's FSH. And LH, luteinizing hormone, of course, more people aren't familiar with as it helps with ovulation, so coming later in the cycle. But the reason we want to test those early around day 3 to 5 is it tells me how well the brain and the ovaries are communicating. So I'm looking for those numbers to actually be on the lower end of the reference range, ideally at or under 7 for both of them. And then I also want to check that estradiol isn't too high. Because if estradiol is too high, generally if it's above 50, it can falsely suppress FSH. So I can get a false picture of a good communication if that estrogen's high. So those 3 together in that day 3 draw are super helpful. And then when we talk about hormones later on, the 7 days after ovulation is because that's when progesterone can be detected and measured. And progesterone is our progestational hormone. She will only be made in a significant amount if we ovulated. So it's another way of confirming, aside from like body temp rise and those other kind of less invasive tools we can do.
So are all doctors testing these hormones? Is there like a standard hormone panel?
If you just did your let's talk about like your routine annual
By the way,
screening.
I don't think any doctor in my life other than you has ever been like, we're testing on these days of your cycle, or even had that as a part of it.
Right.
By the way, I think I messed it up our last test. It wasn't the right day of the cycle. So we can redo that one.
We can redo that one. Your favorite, more blood draws.
Yeah.
It's unfortunately, no, it's not standard of care to test hormones, period. Like your TSH is like the one hormone that gets included. I will definitely credit there are some wonderful OB-GYNs out there that do advocate for that and do tests for that. Sometimes there's knowledge on the day of the cycle, sometimes not, because if you waited a few months to see your OB and they're going to do blood that day, they may not have you come back on another day of your cycle. And so if we were to ask for like a standard hormone panel, that would look differently for every provider. So what I would say is we could, if we needed to, we could skip that day 3 to 5. That's like my additional beefer in regards to that's my additional in regards to just having more information, especially for my first-time patients or just those that are like, I want everything. But we could skip that day 3 to 5 and just do the 7 days after ovulation, because at that point, we can still measure our estrogen levels and our progesterone levels. We can still check for our testosterone levels. We don't want too much androgen, meaning male type hormones. Yeah. So if you're going to
we're sacrificing a little bit of accuracy, but we're still getting a great picture if we only test 3 to 5 of the cycle.
Absolutely, yeah. So if we don't do the 3 to 5, we're still going to get a lot of info. By the way, 3 to 5, this is 3
to 5 days after your period.
Great point, and thank you for asking. Day 1's always first day of like full flow. So that's always going to be day 1 that we count, and then we count upwards. So day 3 being obviously a few days after that. And then the reason I'm saying 7 days after ovulation is some people have heard day 19 to 21 of their cycle being that window. And that's based on the stereotypical textbook perfect female who has a 28-day cycle. She ovulates day 14, right in the middle. And so day 19 to 21 is 7 days after ovulation. So to clarify, in case you ovulate a little earlier, a little later, that's why I'm specifically saying 7 days after ovulation. So we'll get a better window and a better picture of time at that point. And so what we're asking for, so if it's like, okay, what am I writing down? What am I going and asking my doctor for? If we're talking about hormones, because again, hormones could include thyroid, it could include so many things. You could ask for like wanting my sex hormones or my female hormones tested. I specifically want to see estradiol, progesterone, testosterone, free and total is really important there, and DHEA-S or sulfate. So those 4 hormones together are really helpful to measure at that time. And DHEA, because I don't know if that one's as well known or verbalized in the medical community, or people probably don't know they're even being tested for it. It's a hormone that's actually produced by the adrenal glands. So they sit on top of the kidneys like little hats. That's how I like to think of them. And DHEA acts kind of like a precursor hormone. So it's going to help your body make other hormones. Not that it doesn't have any value itself, but it's kind of there as like that pool and resource. Part of why DHEA can be super helpful is it's considered an androgen, just meaning a male type hormone. So as females, we should have less than our male counterparts, and an excess of it could be indicative of something like PCOS or polycystic ovarian syndrome, and that excess could be a block or inhibition of ovulation to occur. So just be helpful information to have. The other thing that
and then you're also saying, and I want all of this on day 3 to 5.
No, day 3 to 5 is just the FSH, LH, and estradiol.
Got it.
And then these other ones are going to be 7 days after ovulation, which is for most roughly around day 19 to 21. And so that would, at least those are the things you can list for. And the reason I specified testosterone free and total is I like to think of it as if testosterone rides on a little school bus in our bloodstream. And that's
making all of these sex hormones very adorable.
I know, they're cute, right?
Little
They're
school buses.
You know, I talk to my male patients the same way, and I just love that they kind of shrivel up a little bit sometimes. And I'm like, I feminize all of them because that just makes it feel right. Yeah, exactly. So testosterone rides on this little school bus in our bloodstream. That school bus is what we call sex hormone binding globulin. Super long name, SHBG for short. Just a binding protein, just what carries it around. But for as long as it's on that bus or attached to that protein, we can't really make use of it. It's the free testosterone, that which is unbound and or off the bus, that kind of not wreaks havoc, but in excess it could, that has impacts on our system. And so I want to see how much total testosterone's in your picture and then how much of it is off the bus. Because something that people may not know, and that's where measuring sex hormone binding globulin itself can be helpful. But as females, if we've ever been on oral birth control, we actually can increase sex hormone binding globulin, and that elevation can actually persist for years or decades after finishing the birth control pill. And so that can rob us.
I was on birth control for many years.
Yeah, as was I. That was like the thing to do.
Yeah.
It came with your Tamagotchi, I think.
Yeah.
And so having that information is really helpful because later in life, it can rob us of some of that testosterone. And while yes, testosterone is a more male pattern hormone, it's still super important for us as females, helpful for us in developing our eggs and those ovarian follicles. So just important information to have. So as a recap, hormone-wise, we talked about the thyroid. We're going to ask for TSH, high sensitivity, free T3, free T4, and Hashimoto's antibodies. Write those down, love it. If we're going to lucky enough to do 2 draws for our cycle, day 1, we're flowing, we're in the thick of the bleeding, most of us. Day 3 to 5, we're going to maybe do that first draw if we're lucky. Again, this is the one we could skip if we needed for simplicity. That day 3 to 5 is going to include FSH, LH, and estradiol. And then if we shift to 7 days after ovulation, we're going to add some extra hormones. I like to see estradiol again, progesterone, testosterone free and total, DHEA-S, just meaning sulfates, the more predominant form. And then if we're lucky, we could add SHBG, that binding protein.
And this second hormone draw, if we want to do less blood work, we can just do that one.
Yes, exactly. Because that's also a good time to test all of the other things. Obviously, we're talking a lot about like hormones. There's a lot of factors about metabolic health. And I guess the one I didn't mention if we're speaking on hormones is, of course, our friend cortisol. I like to say friend or foe because I love her. She's great. She gets a lot of bad rep in social media, TikTok, like scrolling is like, no one likes cortisol.
Face.
I'm like, none of us would be here if she wasn't here. So like, we do have to love and appreciate her. But I think all of us have experienced like those high cortisol moments or yes, the puffy face or like more water retention, more inflamed. And so cortisol at the right amount at the right time of day is super pertinent for life. And so that's a helpful one to add in as well. That's not necessarily a do or die. Again, I'm picturing someone going to like their primary care and thinking like, what's the most we could push them for? And I'm trying to think of like the high value, high ticket. And I think the sex hormones would certainly supersede the cortisol, but obviously we've
Thyroid
always
and
tested
sex
that.
hormones are like
Totally.
the essentials. Ask for this. By the way, do most primary care or most OBs, so they test the TSH, but they're not testing any of these sex hormones. They're not, I'm so like desensitized to testing because you're my doctor, so I just don't know.
Right, yes. No, you're right. In that's not being tested. Generally what's included is just like a basic, what we call complete blood count. Just looks at your red blood cells, your immune system.
Because you don't know, when you're at the doctor, at least if you're me.
Yeah.
I think most of us, you don't know what they're testing. They're like, yeah, we're going to do blood work. And you're like, great, you got it, all the blood work, we're all covered. But if they're doing blood work for like 3 things and ignoring all of these other variables, it's not really the picture you want.
Right, exactly. Yeah. And I hate that we go back to like what's standard of care, but that's really what their justification is just like that's how they were trained and that's what we're supposed to draw at a minimum. I think, obviously our experience has been different. And I think what I love about my field as naturopathic doctor is we want to be preventative. And in order to do so, I need to see like hindsight of like, okay, what's coming? Is there some signs of blood sugar dysregulation that could develop into prediabetes? Like we have ways of measuring this. So in my mind, I'm like, why would we not? So I hear you. And sometimes when people come in and they're like, I just had blood work done, like we can use that. And I'm like, it's got 3 things on it and you weren't even fasting.
What are like the few things that they're testing? And yeah, it's quite possibly not at the right time.
Right.
Not fasted, no consideration of when your cycle is. It's basically when you can get an appointment, I think, for most people.
Totally.
So what are the things they are testing if you're just going off standard of care?
A basic panel is generally going to include what's called a complete blood count, and that looks at your red blood cells, your immune system function, so just basic signs of infection, also looking for signs of anemia, which is generally an underproduction of red blood cells. So it's like, okay, check, that's not the issue. Other one might even be a basic metabolic panel or a comprehensive metabolic panel, just different variations of each other. They're going to look at your electrolytes, liver, kidney function on a really basic level. Still super helpful, but that would be in there. TSH maybe a hemoglobin A1C, which is roughly our 3-month average of our blood sugar control. Hemoglobin A1C is different than hemoglobin itself. The hemoglobin A1C, again, more of that 3-month average. I like to think of it and describe it as if our red blood cells are hanging out, and this test is measuring the percentage of them that have little sugar molecules stuck to their surface. So if you can picture over the last 3 months, if you've been really going to town on Sour Patch Kids, you've had more, that's a shout out to myself. You've been having more blood sugar fluctuation.
It's like kind of subtle dig.
Yeah, it's okay. You're going to have more variations in your blood sugar throughout the day. And those higher the spikes, the more that the sugar is going to be around in your system and able to attach and get stuck to those red blood cells. And then they become what's called glycosylated, just meaning sugar stuck to it. And then they don't function as well. All of this to say that A1C helps us determine a healthy range, a pre-diabetic range, and or a diabetic range. And there's a difference between being like high normal, close to prediabetes, or like really lower and, on a good part of the range. So that may or may not be included. And from my experience, that's kind of where it stops. Sometimes there's a lipid panel in there, just looking at cholesterol levels, but not always. That tends to be kind of where they
trying to have a baby.
Yeah.
Oftentimes.
A healthy baby too, right? And a healthy pregnancy.
Oftentimes utilizing sex as the technology to create the baby.
Yeah.
And we're not testing sex hormones.
Right.
That's crazy.
And we're also not checking sperm most of the time. I know we did, have a whole episode on for men, but just things that you think would be so simple
you really
and
have to
straightforward.
advocate. So all of the things you just mentioned, those were all the basics you did for my first pregnancy. And then I remember we also looked at if I methylate or not. Now I think most prenatals have methylated vitamin B, but I don't methylate. So what does that mean? Should people still be testing for that?
You can ask for that. In my experience, insurance coverage isn't wonderful, but sometimes things like 23andMe, if I can't recall if that does test it or not.
Or do you just take a methylated prenatal?
Yes, generally a methylated prenatal is what people will use. However, in the OB community, it's still a standard of care to give folic acid, which is not a methylated form. And in some research, giving the folic acid, even in those with MTHFR mutations, is still safe and is indicated. In my experience, there also is research that shows that folic acid in high amounts in those who don't methylate can have negative outcomes. So all that to say, have the conversation with your provider. I can recognize there's strong oppositions to that.
I think I was taking methylated folic acid and then you took me off of it. You were like, we don't need this. You're
Yeah, because
fine,
we
but,
had
like,
a
we
good
don't
amount
need
in your
this.
prenatal.
Yeah.
Yeah,
Mhm.
exactly. Yeah.
Okay, so those are the basics. That's what you tested for my first pregnancy.
Yeah. And that was hormone-wise, because that didn't necessarily highlight some of the metabolic parameters.
Yeah.
But yes, hormone-wise.
But that was all the testing we did, right?
We did also look at metabolic markers of health as well. So
Which ones of those did we look at?
So for you and that first pregnancy, what I think is also helpful is, I mean, I would consider it a standard, maybe not everyone would. A fasting cholesterol panel. Fasting is so key. You're going to have higher cholesterol if you have just eaten. So it needs to be fasted. And why that cholesterol is helpful is if we have an excess or what we call hyperlipidemia, whether it's mixed or pure, just meaning if we have high triglycerides and high cholesterol or just high cholesterol, that together, if it's elevated, can put a lot of stress on our system, contributing to inflammation and oxidative stress. And if we're in a position where, and unfortunately, just the world that we live in, where we're surrounded by oxidative stress, and then we're also having that internally with high cholesterol, that can be something worth addressing. So I like having that information. I think that's really important. And with that, and something that's not tested, but I'm like fingers, toes, arms, legs crossed, I hope changes, is something called ApoB or apolipoprotein B. She's my all-time favorite marker of what I like to think of the risk that you carry with your cholesterol levels. It's one thing to just look at your total cholesterol. It's another thing to understand, okay, does this put me at a higher risk for plaque buildup? And then the things that can happen like heart disease or stroke, or does it not?
I forget if I was really high or really low with that.
With ApoB,
Yeah.
I believe she looked great for you, if I remember correctly.
Yeah, that was one of my good ones.
Yeah.
My thyroid's not great, but you know.
And so ApoB, because I don't think many people have heard of it, is apolipoprotein B. I think of it as cholesterol is a fatty molecule. In order for us to mix that in water, which is our bloodstream, it has to be put inside of a protein. So little cholesterol molecules hang out in these proteins. How these proteins differ is exactly how some people probably don't even realize they've been referring to them. It's like LDL is low density lipoprotein, just a protein that carries cholesterol around. We have HDL, high density, so on and so forth. So ApoB is an additional surface protein. So it just hangs out on top of that other protein. And why it's important is that ApoB makes it that it's a much higher risk of developing plaque or contributing to plaque buildup than if it's not there.
So if you have these things, is it lifestyle modification, eating healthier, less fast food, more exercising?
Yes, it's kind of a mix of all of them. So
and it would kind of tell you, like, during your pregnancy, you really want to consider your diet.
Exactly.
How does that affect the outcome for the baby?
It more of an inflammatory standpoint. If your blood, because obviously, we're sharing with babies. So if we have more inflammation going into baby, it's putting them in a stressful situation, like right from the beginning. And so, yes, those lifestyle modifications, higher dietary fiber intake, less carbohydrates or simple sugars within the diet, those things can certainly help lower that. And in doing so, we can help lower that burden on your body, but also on babies during pregnancy. Sometimes there's genetic components that make us more likely to have this. I have heart disease on both sides of my family, so it's something that's always top of mind for me. I tend to run high even when I think I'm eating really well, so I just have to be that much more diligent personally. And so I think it's information to have. And again, not necessarily you have to, but I think if we're talking about everything possible that we could test, it's a wonderful thing to add in.
By the way, I just want to say, I think a lot of people are afraid of testing. My husband's one of them. You have to chase him around with needles. So I understand that because, it's tricky. Like, you don't want to get difficult information. And I just want to say for everyone, I think I'm pretty healthy. Like, I'm 80-20 with how I eat and all the things, and I live my life, but I'm pretty healthy. And I have hypothyroidism, and it was really important for me to discover that. It was a part of me getting pregnant. It was a part of me having a healthy pregnancy and healthy outcome.
Right.
You are a glowing goddess, the picture of health, and you have this cholesterol gene. So just, it's important to help us make the right assessment and make the right choices. So for people who are avoiding testing, you shouldn't really.
Yeah, and I can totally resonate with that because it can be anxiety provoking to go into that state where like you could receive information that's less favorable, but you also could receive information that you would be surprised by. Like, hey, yes, maybe X, Y, and Z need some love, but you are crushing it in these other areas. And I think that is generally how most of my appointments go with my patients of like, hey, these are things I can help you with and we can adjust. Here's the things that are going really well that we're going to celebrate. And like you said, I'm 80-20 my diet. Totally. I jokingly say Sour Patch Kids. I'm not proud of it. They've made their way into my system more times than I'd like them to. That's okay. But that doesn't mean that's a daily occurrence. And mindful, don't really consume alcohol. Like, those things factor in totally. But for some of us, those genetic components can just put us at a higher risk. Doesn't mean we're doomed or destined for that. But like you said, having that information I just think is super helpful. And that's where I think just advocating for yourself to get the labs that you want is so important. And you can. And I think the beautiful part of where we're at now is the opportunity to self-order that you've experienced, that I've helped coach you through, of if you're in between providers, if you're just not happy with who you're seeing and you're trying to find someone else that you really jive with, that you feel like is going to give you the answers you're looking for, you can order your own blood work. I want to hold and say, please don't try and interpret it and diagnose yourself. Please, 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 please.
It's very stressful.
It's so stressful.
I've done
Dr. Google
it before.
and ChatGPT will tell you very bad things that will probably not be true. Like, please see a licensed healthcare doctor to go over it, a healthcare provider, sorry. But you can get the information. So like if you're being met with, no, we're just going to test this, you can go, okay, thank you, but I'm still going to run this additional thing on that same day. And then you can go back to them and be like, okay, now here's all the information. And I just think that's beautiful that we're in a place now where we can do that.
It's amazing. I mean, my preference is obviously to come see you in Arizona, but given my work and life, there's been many times where you've been like, okay, I'm ordering this test. You go to your local lab. I stand in a line, get some blood work done, and then you go over the results with me, and it's really helpful.
Right, exactly. And so we'll include in the show notes for everyone ways in which they could explore that, just so that they have that avenue.
Okay, so we've gone over my first pregnancy basics that you test for, which are not the standard of care and are definitely more than, I would say, what 90% of people are probably getting when they go to see a physician. Now, what did we do this most recent time? Because that was so many vials.
We did all of the things, which I love. We did all of the things. We dove even deeper into your metabolic health. Some of these were still included in that first panel, but we included things like your fasting insulin, which is so important. I want to see when you're at a place where you haven't eaten anything, what does that insulin level look like? Because insulin resistance, which just means your cells are not responding as well to that insulin signal, develops long before prediabetes is present and well before diabetes. So it's like if I can catch you in a state of insulin resistance, I can correct it before we even kiss
prediabetes. And so to do this, that's why I had to test first thing in the morning before I ate.
Yeah, exactly. So most of this is fasted just for simplicity's sake. Other hormones we included this time just to be additional was, actually I think it may have been included the first time, probably was, prolactin. So prolactin is a hormone you became well acquainted with as you were lactating / still are
through the roofs?
Actually, no, not
really.
Well,
wait, I think I was weaning when I did my last.
Yeah, you were weaning when we last did it. But the first time that we tested it looked great. The reason I test prolactin is, well, yes, it's our prolactational hormone, helps with milk production. It is something that can get inappropriately produced by the brain and can disrupt our menstrual cycles. So it's something that can block ovulation, can cause headaches. It's generally secreted by something called the prolactinoma, just a benign growth. Benign meaning non-cancerous, but it does release prolactin and can wreak havoc on our system. So that's really important one that gets missed both for men and women, but I think an important one to mention. The other things that we did this time that were different is we looked for some heavy metals in the bloodstream. And this will tell us more recent exposure, meaning like within the previous small amount of time. If we wanted long-term exposure, we have to do more of like a urine, like a provoked urine test. But nonetheless, the heavy metals in the bloodstream was an additional one. We also did a more extensive cholesterol panel, which I love. I would run this on absolutely everyone if they would be down.
Were there any surprises given the sort of simpler cholesterol panel we've done versus the recent extreme one?
Not necessarily, no. The one thing I will say that we noticed is, so the more extensive one is going to tell you like the particle numbers. It's going to do a little bit better job at quantifying. It's called an NMR lipoprofile generally. It's going to quantify the number of LDL particles, which are ones that have the ApoB on their surface that can contribute to plaque buildup. It's also going to tell me the size and shape. I want if you have LDL particles, for them to be big, floaty, bouncy, less likely to get stuck. The small ones I think of as like fine dust. When they go through the blood vessel wall, they just get stuck in every nook and cranny. And then that's when that plaque buildup can really start. And I think I don't want to say like a surprise, but one thing that I did notice on your blood panel was we had a lot of what we call oxidized LDL. And what that means is just that it's kind of like it's been activated or reactivated in the bloodstream and more inflammatory in nature. So while your cholesterol panel itself was not alarming whatsoever, we had some more inflammation, which I think was more and likely more related to stress, given, the fires, unfortunately, that you had to undergo, uprooting and moving to a space that was intended to be more safe, having some heavy metal exposure in different spaces. So I think a lot of that can absolutely factor into that oxidized LDL. But that just goes to show that if we just scratch the surface, we could be missing, the other areas of information.
What are like the 5 additional things if we want to go hard?
5 additional things. I would include on there a test that's called ANA, or anti-nuclear antibody. It's a way that we can do a more general screening for autoimmunity in the body. I like to think of it as like we're casting a wide net in the bloodstream to see if there's other signs of just autoimmune disease.
Will it tell you what sort of autoimmune? Because I'm autoimmune. Did it?
Great.
How specific is it? Or it's just like, you have autoimmune, let's explore.
More the latter. So yes, if there is a positive, it gives you a titer, just the way that it reads the test. And then it will test for different antibodies that are associated with different conditions. So it can help narrow in, but it's generally not diagnostic of a specific test itself. It's more so like, hey, something's been flagged here. We need to investigate it further. So it can be helpful. And the reason I say that is because autoimmune diseases can be exacerbated during pregnancy, so it can be helpful to know beforehand if we didn't. They can be a cause of miscarriages earlier in pregnancy, so I think it's, again, helpful to know, and can just be a cause of inflammation within the system, so again, just more information to know. So I think that would certainly be one of them. Another one that I'm a huge fan of is what we call an omega check, or looking for the percentage of omega-3 fatty acids, ideally within the red blood cell wall, but some will do whole blood measurements too. And why that's helpful is, for me, I like to use it as like, how's the quality of the fish oil that you're taking? Because obviously most of us, sure, we could go to Costco, great bang for our buck. It's really not going to move the needle, and it may potentially be doing more harm than good, being that some of them aren't heavy metal tested. They aren't really shelf stable, like they're not providing a lot of benefit. And that omega-3 fatty acid index, or that percentage, can tell us how healthy the membranes of our cells are. The healthier they are, I like to think of like they're juicy, like just like a nice like piece of fish. The healthier that those are, then the better that everything in our system functions, and can help correlate to healthier ovaries and healthier oocytes, or what we call eggs. I'm trying to think of other ones that, aside from what we talked about, I think honestly on there really needs to be the fasting insulin. Like that is another top 3. We can do something called a HOMA-IR calculation that we can use to detect or diagnose insulin resistance. Super easy calculation with your fasting blood sugar as well as your fasting insulin. So I think that's super helpful, because individuals who have something like PCOS or polycystic ovarian syndrome are more likely to be insulin resistant. And the way I explain why that factors into fertility is, if you can picture your cell deprived of sugar, and sugar is like, again, currency for the cell. It needs it to function, period. Every cell in the body ideally uses glucose. If it cannot get sugar in, that's because of insulin resistance. Insulin is there trying to like tap on the cell wall, being like, hey, there's sugar in the bloodstream. Take it in whenever you're ready. And the cell just doesn't hear that signal. That cell is deprived of what it needs to grow and fuel. And that happens at the ovaries. I think we think of it as like, oh, I'm gaining weight from it, or like this is happening. And those things can factor in totally. But the other area is like, if our eggs do not have the sugar that they need, they're super, super dense in mitochondria, just meaning they need a lot of that sugar to function. And so if they don't have that, that can be a huge factor. So I think insulin would certainly be on that list. And then in addition to that, I know we already touched on it, but really the Hashimoto's thyroiditis and those antibodies are huge. That would be 4. And actually 5th, I'm going to add in an iron panel. It is unfortunately so common to find iron deficiency, especially in menstruating females. And some will be like, well, yeah, of course, we're like losing blood. Yes. However, we've got to be mindful of how much blood we're losing, which we talk about in other episodes. However, the reason that I mention that is because iron deficiency can be a cause also of early miscarriage or pregnancy loss. And correcting that iron deficiency can help immensely. Yeah. And also can help you throughout pregnancy. Really common for a lot of women to develop iron deficiency in pregnancy. So if we're
I did develop that.
yeah. So if we start in this depleted state and you just get more and more depleted, it's like, okay, we're so much worse off later on.
And that must affect energy and just how you feel during your pregnancy.
Absolutely. And just your ability, because why iron is such a factor is we use iron to make hemoglobin, which is the protein within the red blood cell. And that protein is what carries oxygen around. And so if you don't have enough iron, you don't make a lot of that protein, and you really suck about moving oxygen around. And just as what I was saying about glucose being so important, so is oxygen. Those are like the two things that our cells and our bodies need to function properly. So I think that would probably be like the fifth that is not tested commonly.
But this
absolutely
is so helpful. Thank you so much for sharing all of this. It is unfortunately so hard to figure all of this out, and there is so much to navigate and so many changes when it comes to getting pregnant, being pregnant, the whole thing.
Absolutely.
So I think this is a really important episode. So thank you.
Yeah, absolutely. Thank you. I'm just excited for people to have tools that they can now go to their healthcare providers and be like, hey, this is what I really need, and that they can get the answers that they want so that they can create the healthy families that they want and have the best pregnancy possible. So thank you.